Thanks for joining us again. I think we're probably about 2/3 the way through this series. Just our usual reminders, don't disclose any private health information during our case discussions. Here's the usual contact information. A little bit about cardio. It's hard to believe it's been almost 7 years. And this is the leadership team. Today, I will facilitate as usual, and I want to welcome Revital, who is a colleague of mine peripherally in cardiology, cardiovascular prevention, obesity care, all those things that we talk about so much here, as well as our own Danette, who will be presenting today. Karen and Jim are who I've asked to discuss the case, which will be presented by Angela Pleasant, who's one of our community health workers who's participating. Usual disclosures, there are no changes related to this activity. And we're going to talk about cardiovascular risk and the menopause. And I think we can take it away.
Thank you very much for introducing us, Gautam, this morning. Can you guys all hear me?
Yep.
Okay, good. So Danette and I have the following objectives for this morning. We want to go ahead and describe the changes in cardiovascular risk among women experiencing menopause, list and describe any key elements of clinical evaluation of menopausal women, including assessment of cardiovascular risk, and describe a strategy for counseling perimenopausal women about cardiovascular risk. The World Health Organization has noted that the obesity prevalence has actually tripled in the last few decades. And most of the world's population live in countries where overweight and obesity kills more people than underweight. And when we remember kind of back to our teaching, it used to be that it was really, undereating and famine that was more of a prevalence. But right now, actually, most of the world is struggling with obesity. And it's really no longer just a high-income country problem. In fact, obesity seems to be more prevalent among the lower socioeconomic because of the fast food world that has become quite prevalent in our society. When we look at the worldwide issues that obesity and cardiovascular disease affects, we see that obesity affects 671 million individuals, cardiovascular disease very close behind, and type 2 diabetes as well. This is not only problematic in terms of health, but also financial issues. Now, when we're studying, interestingly, the evolution of the human diet, I always kind of think that we should understand how we have developed over evolution. So interestingly, when you study the fossil evidence of early human ancestors, they were really primarily fruit eaters. And the major shift in the human evolution occurred about 1.8 million years ago with Homo erectus. And these individuals essentially developed greater hunting skills, and they also developed control of fire. And this allowed them to mature their diets. And then eventually there was a shifting into more complex agriculture and grain-based foods in the Homo sapiens. So obviously, we've all seen this cartoon of kind of how we've progressed over evolution. And unfortunately, we are in 2023, 2024, not in the right direction. So now, in terms of kind of an understanding of how nutrition plays a role, in today's world, we very clearly understand the relationship of nutrition to our health. But that actually hasn't been in existence for that long. And if we go back to 1747, there was a gentleman named James Lind, and he discovered at that time that if individuals were eating fruit, they could prevent scurvy. Now, this was actually 200 years prior to the isolation of vitamin C. And then over the decades, we've been able to understand the relationship of vitamin and nutrients and how they've contributed to our overall health. So in the early 1800s, there was the first scientific report of the benefits of fasting. There was actually Dr. Joslin, who we're all familiar with out of Boston, that published the Rockefeller series in the 1920s. And this is when he understood that the ketogenic diet, or as he called it, the starvation diet, was actually quite beneficial for diabetes. Though at that time, he didn't isolate the differences between type 1 and type 2. So obviously, the ketogenic diet was not as safe for the type 1 population. And then since the 1970s, there was a shift about nutrition policy and kind of its relationship to chronic disease. And so we've gotten more sophisticated in our understanding of how nutrition and lifestyle affects our overall health. Specifically, when it comes to heart disease, it's been documented that about 2,200 adults die daily in the United States due to cardiovascular disease. And obesity increases the risk of this cardiovascular disease by at least twofold. We know that heart disease and stroke risk factors include unhealthy diet, visceral adiposity, which I will explain in a second, physical inactivity and sedentary lifestyle, which certainly has worsened since COVID, tobacco use, and harmful use of alcohol. Now, in terms of visceral adiposity, this is really the adipose location in the abdominal cavity. And we've come to understand that this is really the metabolically active fat. And we know that visceral adiposity, which we can't really specifically control in terms of our ability to lose weight, like we can't really work specifically on losing more fat in that location, but we know that this contributes to the metabolic syndrome, which, as we've studied, contributes to hypertension, hyperlipidemia, cardiovascular disease, type 2 diabetes, fatty liver, as well as several cancers. In terms of how nutrition contributes to the metabolic syndrome, added sugars, excessive salt, refined foods, I think that this kind of defines the all-American diet, unhealthy fats, and low intake of fresh vegetables, fruit, whole grains, fibers, fish, and nuts. All of these will contribute to unhealthy nutrition habits as well as the metabolic syndrome. And the dietary interventions that have been shown in the literature to impact cardiovascular disease include the following. Some combination of all of these have been shown to help cardiovascular disease, from calorie restriction, fat restriction, the Mediterranean diet, which is probably the ideal approach, the DASH diet, which is an offshoot of the Mediterranean diet. Essentially, it is the Mediterranean diet, but more low salt as its focus, the ketogenic diet, plant-based diet, and intermittent fasting. I will go into detail just about on a few of these in the following slides. So specifically, let's kind of delve into the Mediterranean diet for a second. The Mediterranean diet has been described as one of the first studied probably in the 1960s, and it originated from the eating habits of the then 22 countries that surrounded the Mediterranean Sea. And maybe they're not necessarily eating this way now, but at the time, it was described as a high intake of vegetables and whole grain cereals, extra virgin olive oil as a source of oil, fruit, tree nuts, a moderate intake of fish and poultry and wine, and as low as possible intake of dairy, red meat, processed meats, and sweets. And this was really demonstrated to be a full, rich lifestyle approach to eating. It wasn't really considered, quote, diet as we think about in terms of weight loss. Now, the PREDIMED study was a landmark study that evaluated the Mediterranean diet. And this was a study that originated out of Spain. And it was a parallel group, multi-center, randomized controlled study where they enrolled over 7,000 individuals who were at high risk for cardiovascular disease. So at the time, though, they did not have documented cardiovascular disease at baseline. And they evaluated them over 4.8 years. They stratified these patients into three groups, either a Mediterranean diet with extra virgin olive oil, a Mediterranean diet with mixed nuts, or just a control group. And they did not actually specify a total calorie restriction. What they did see is that over those 4.8 years, the Mediterranean diets, both groups, both with the extra virgin olive oil and the mixed nuts, resulted in a 30% relative risk reduction in cardiovascular events in these high-risk individuals. So they noted this 30% reduction in the risk of MI, stroke, cardiovascular death, as well as new onset of type 2 diabetes. They additionally showed improvement in the lipoprotein function as well as increased anti-inflammatory and antioxidant capacities. So this was a really important landmark study that showed the benefits of the Mediterranean diet in terms of cardiovascular health. Now, in terms of the menopausal transition, what we know is that at that time of life, there's depletion of ovarian follicles. And this leads to decreased ovarian follicle responsiveness to the pituitary gonadotropin, specifically follicle stimulating hormone and luteinizing hormone. And this then leads to lower serum levels of ovarian hormones, specifically estrogen and progesterone. And as a consequence of the lowering of these hormones, these women, everyone, will develop, some of them will develop vasomotor symptoms, hot flashes, vaginal dryness, osteoporosis, cardiovascular disease, as well as there's a risk of breast cancer. So this is a difficult time in a woman's life. And the Mediterranean diet and menopause, there's been a lot of documented studies that have shown that there's worsening of menopausal symptoms shown during this time. They've documented that intake of legumes and extra virgin olive oil has been associated with a lower severity of menopausal and psychological symptoms. Soy intake, which is a known legume, has been shown in several studies to be of help. Soy, which breaks down into isoflavones, is a similar chemical structure to estrogen. And dietary phytoestrogens are bioactive compounds with estrogenic activity. So phytoestrogen-rich foods can include fruit, vegetables, soy products, seeds, nuts, legumes, and whole grains. So increased consumption of this around the time of postmenopause can potentially help with some of the symptoms. So in terms of the effects of dietary phytoestrogens at the different stages of life, it's not, these aren't 100% proven, but what they've noticed is that for children, it doesn't necessarily contribute to significant positive effects. We don't really know if this is positive or negative. It seems like throughout life there is potentially goiterogenic effects, so that's not necessarily a positive thing. In men, they've shown reduction of insulin as well as improvements in fatty liver. In the premenopausal time frame, there's been no observed effects with phytoestrogens. However, in the postmenopausal women, there has been some studies that have shown beneficial effects on glycemic control and cardiovascular markers. And in the pregnant woman phase, there's been improvement of insulin metabolism. So in terms of recommendations for patients, phytoestrogen intake, it's not 100% obviously proven one way or another, but there has been some potential benefits that have been shown in the literature. So let's talk briefly about the plant-based diets. The plant-based diets are characterized by an intake specifically of a higher amount of plant products and a reduction or elimination completely of animal-based foods. But there is kind of a spectrum. There are a variety of plant-based diet eaters. Some are completely extreme, so they're vegan, so they eat absolutely no animal products. But then some will have some eggs or cheese or milk. Others will be pesco-vegetarians, which means that they've added fish products. And then, of course, there is the opposite extreme, which is the non-plant-based diets, which is they're omnivores. Now, plant-based diets have been shown in large prospective cohort studies to exhibit lower all-cause mortality, improvements in cardiovascular related mortality, as well as less cardiometabolic risk than meat eaters. In fact, there has been some documentation of reduction in coronary heart disease events by 40%, as well as risk of cerebral vascular disease by a decrease of 29%. So kind of reviewing the landmark studies regarding plant-based diets, I thought this was kind of an interesting intervention. The Adventist Health Study 2 was looking at a population of patients that are all attending the Seventh-day Adventist Church. And what they evaluated here, so this is a religious group, that promotes vegetarianism. So they evaluated over 41,000 individuals who were not diabetic at baseline, and their goal was to detect the development of diabetes in the different subcategories of plant-based diets. And of the different vegetarian subcategories, it was really the vegan patients that showed the greatest risk reduction, and they actually demonstrated a 77% risk reduction in developing diabetes. Now, here we go, that. Now, the lifestyle heart trial was actually a very exciting randomized control study that was published in the 1990s. And this was really the first randomized controlled clinical trial to determine if patients with known coronary artery disease can develop regression of coronary atherosclerosis with lifestyle changes. So this was actually very exciting. And they randomized 48 patients to either an experimental group or a control group. And the experimental group included a low-fat vegetarian diet, a moderate aerobic exercise, stress management, smoking cessation, and group support. So kind of an ideal multi-sensory, multidisciplinary approach to care. And what they noticed is that at 1 year in the experimental group, so the group that received that kind of intervention and were specifically low-fat vegetarian diet, there was significant diameter stenosis regression of their atherosclerosis. While in the control group, there was a progression of their stenosis. And they continued this study for a 4-year extension. So 35 of the original 48 patients continued on for a total of 5 years. And their primary endpoint was percent diameter stenosis. And they showed that those that continued in the 5 years in the experimental group had improvement in their coronary patency. And so in contrast to that, the control group actually, as predicted, showed progression of stenosis. So the take-home message with a plant-based diet is that the veganism, which is the most extreme, has actually been probably the only diet in the literature that has been shown to show regression of coronary artery disease, which is quite remarkable in terms of how lifestyle modifications can contribute to heart disease. I will then now pass on to my colleague, Danette. Thank you for having me.
Thank you, Revital. Danette, whenever you're ready.
Yeah, thank you. So I want to start by just acknowledging Sally McFedrin, Corinne Bozzella, Jean Marino, and Gautam Rao for contributing to some of these slides. And so in the second half of this presentation, I'm going to give a brief overview about the menopause characteristics and cardiovascular disease risks, some controversial and non-controversial information about menopause hormone therapy, and what we can do to help reduce the risk for cardiovascular disease in menopausal women. And some of these slides I'm going to just skip over because Dr. Gorodeski Baskin has covered them already. Okay, next slide, please. So cardiovascular disease is the leading cause of death for women worldwide, and it occurs mostly after women are 55 years old, which is during the postmenopausal years. The average age of menopause is 51 years old, and to be considered postmenopausal, a woman has to have 12 consecutive months of no menstrual cycles. But what has also been found and established is that premature, early, or surgical menopause are risk factors for cardiovascular disease. Next slide, please. So traditional risk factors were reviewed earlier, diabetes, smoking, excess weight, physical inactivity, hypertension, and dyslipidemia. Next slide, please. Non-traditional risk factors for women to look at: preterm labor, intrauterine growth restriction, hypertensive disorders of pregnancy, breast cancer treatment, autoimmune disease, and depression. Next slide. This slide here is just for your reference if you want to look at the American Heart Association's scientific statement about menopause transition and cardiovascular disease risk. Next slide, please. So early onset of natural menopause is defined as if a woman transitions into menopause before she's 45, and premature if she transitions before she's 40. In both, for both, there's an increased incidence of cardiovascular disease, morbidity, and mortality. And for early onset menopause, there's also an increased risk for heart failure and fatal congenital heart defects. And if a woman transitions into menopause before she's 35, there's a 2 to 3-fold increased risk of myocardial infarction. Next slide, please. So estrogen is believed to have a protective factor in premenopausal women. And one reason for that is estrogen is known to reduce blood pressure. And when women start to transition into perimenopause and their hormones are fluctuating, and when they're in postmenopause, when the estrogen really depletes, they are they lose that protective factor of estrogen. Next slide, please. So surgical menopause, like if a woman has her both ovaries surgically removed, she's at a higher risk for coronary heart disease with no estrogen hormone therapy compared to women who transition into menopause naturally. But there have been studies that have shown if a woman has this surgical menopause, has this surgery, let's say around the age of 51, then there's a small to no association for coronary heart disease. Next slide, please. So I'm going to focus most of the rest of this presentation on these areas because I think these areas we can actually help women with, and we have some more of a consensus of what we can do. So hot flashes and night sweats or vasomotor symptoms, problems related to sleep disturbance, depression, and weight gain are all common things that I hear women basically are anxiety provoking or become depressing for them during this transition. Next slide, please. So regarding menopause hormone therapy, there's a difference of opinion, and that's kind of what makes being in an academic institution very interesting, from my point of view. So the Menopause Society, formerly known as the North American Menopause Society, and the U.S. Preventive Services Task Force, they have a difference of opinion. Next slide, please. So the Menopause Society, they published a position statement a couple of years ago about hormone therapy. And in that position statement, they recommended that if menopause hormone therapy is initiated younger than 60 or within 10 years of a woman's final menstrual period, then that is the safest time to be on hormone therapy. And they made a lot of these recommendations and conclusions based on observational data, meta-analysis, and preclinical studies that have shown potential benefits for systemic hormone therapy and reducing the risk for cardiovascular disease. But they've also have noted that most randomized controlled trials do not show that menopause hormone therapy can reduce the risk for cardiovascular disease. Next slide, please. So the U.S. Preventive Services Task Force, which Dr. Rao serves on this task force, suggests that there should be more research, assessing menopause hormone therapy use on cardiometabolic effects for women transitioning into menopause. And there is adequate evidence that estrogen and progestin or estrogen alone has no benefit for coronary heart disease. And this task force also recommends against the use of combined estrogen and progestin for the primary prevention of chronic conditions in postmenopausal women, and recommends against the use of estrogen alone for the primary prevention of chronic conditions in postmenopausal persons who have had a hysterectomy. Next slide, please. So there's also authors whose opinion regarding both of these positions. And what they have stated is that the U.S. Preventive Services Task Force guidelines did not use any update literature or evidence to make their recommendations, whereas the Menopause Society were much more up to date using current literature. However, I think they both looked at the literature very differently, whereas the task force looked at a lot of randomized control trials and the Menopause Society looked at, more observational studies. Next slide, please. So other differences of opinion is that hormone replacement therapy is most favorable in the first 10 years post-menopause. There's no cardiovascular disease harm and benefits will ensue. Hormone therapy has to be individualized. There's risk if you continue it long-term. There's more risk if it's oral estrogen or hormone therapy, but not if it's transdermal. And there's a reduced risk in cardiovascular disease being treated with, menopause hormone therapy for younger women, but not older. Next slide, please. So what can we do? Next slide. So I think there is more of a consensus that menopause hormone therapy can be used to treat vasomotor symptoms and genital urinary symptoms of menopause, which is vaginal dryness or pain with sexual activity, and also to prevent bone loss and fractures and, for women going through the transition. Next slide, please. There are also studies that show, regarding why it's so important to treat hot flashes and night sweats. Studies show that there are adverse lipid profiles, insulin resistance, and a greater risk for hypertension. And if women have palpitations in addition to hot flashes and night sweats, they're even at a higher risk for cardiovascular disease compared to women who do not have palpitations and only have vasomotor symptoms. Next slide, please. And so hot flashes and night sweats have also been shown to increase vasodilation and heart rate. Next slide. And what, one of my colleagues has said to me, and I have, definitely this is consistent, is that estrogen has been shown to have the best efficacy to reduce the number and intensity of hot flashes and night sweats, which improves the quality of life for women. Micronized progesterone metabolites are responsible for improved sleep, specifically falling asleep, but not for hot flashes and night sweats. And synthetic progesterones are associated with increased blood pressure. Next slide, please. So menopause hormone therapy is also used to treat, used off-label, like a lot of medications are. And it's used to treat sleep disturbance, particularly if the sleep disturbance is due to night sweats. It's used to treat depression, and there are a few studies that have used it to treat abdominal adiposity. So regarding sleep disturbance, it has an impact on mood, and I don't think that's just for women or menopausal women. It has an impact on weight, problems with memory, metabolic syndrome, and there's a greater risk for cardiovascular disease. Next slide, please. So depression, which, I get a lot of referrals for this for menopausal women during the perimenopausal transition and postmenopause, especially when women do have no idea what's going on with their bodies. But I just want to point out that the Swan Heart study, they did a 5-year follow-up in healthy women, and which showed that if a woman has 3 or more episodes of depression versus no episodes of depression, having these episodes of depression was significantly associated with elevated coronary artery calcification scores. Next slide, please. And the Women's Health Initiative found that depression was an independent predictor of CVD death and all-cause mortality for women with no history of cardiovascular disease after adjusting for established risk factors and demographics. Next slide, please. So estrogen therapy has been shown to have antidepressant effects similar to antidepressant agents. and more so for women with not only depression, but hot flashes and night sweats. It has been found to be ineffective to treat depression in postmenopausal women. And I just want to note that it's not FDA approved to treat depression. Next slide, please. So the positive changes of estrogen, what happens physiologically with oral estrogen, there's a decreased LDL, decreased total cholesterol, increased HDL, and with transdermal estrogen, it lowers LDL, total cholesterol, but has a neutral effect on HDL. Next slide, please. Weight gain, I'm not going to really spend any time with because I feel like Dr. Gorodeski Baskin, she covered that. But I'm just going to point out very quickly that what they're looking at is, waist circumference. And for women who have a waist circumference of less than 34.65, they will have less risk for coronary heart disease compared to women who have waist circumference greater than 35. And they're even more at risk if their waist circumference is more than 35, in addition to being in the class 3 obesity range. And so studies have shown that these lifestyle interventions can prevent weight gain while reducing triglycerides, blood pressure, blood glucose, and insulin. Next slide, please. Just very briefly, the Mediterranean diet, which has already been pointed out, has been the most recommended for menopausal women. And also, exercise 60 to 90 minutes most days. And again, menopause hormone therapy is not FDA approved, though some studies are now, obviously examining the effects of menopause hormone therapy and abdominal adiposity. Next slide, please. So there are many other interventions. I do a lot of cognitive behavioral therapy for hot flashes and night sweats, depression, weight, and sleep disturbance. And then, we also, Dr. Gorodeski Baskin talked about diet and how it can also help. Next slide, please. But just in summary, menopause hormone therapy is controversial. It's accepted to treat menopause symptoms during perimenopause. Other societies and study groups suggest it's an acceptable treatment within 10 years post-menopause, and that it's acceptable to treat early onset surgical and premenopause. Next slide, please. And so when we're talking to women going through this stage, we just want to educate them about the increased risk of cardiovascular disease during the menopause transition. We want to educate them about the risk and benefits of menopause hormone therapy. And we want to use gold standard treatments to treat all of these conditions: hot flashes, night sweats, depression, sleep disturbance, weight, and abdominal adiposity. And that is all I have for today. Thank you.
Thank you, Danette, and thank you, Revital. Fantastic presentations from both of you. And Danette kind of captured the U.S. Preventive Services Task Force, which we actually, because it's such an awkward name, Danette, we call the USPSTF, quite accurately in terms of the position. But the topics that come through the task force are updated roughly every 3 to 5 years. So Danette's absolutely right. We will probably revisit this. The importance of the recommendations is that if the U.S. Preventive Services Task Force recommends something, it has to be covered by insurance without any copays. So that's the across the country, but mandated by Congress to do so. I'm not in the cardiovascular, menopause, women's health domain. My domain is almost exclusively children, but I know that this topic will be coming up sometime, probably in 2025 again. Any additional questions for Revital or Danette before we move on?
One quick question, if I may, Dr. Conklin, Dr. Baskin. I echo great presentations. I'm curious, Danette, about the difference in effects of the oral supplementation and the transdermal. The only apparent quick take I have on that is perhaps blood levels, and I'm just curious, what's your understanding? Is it the lack of peaks and troughs with the transdermal, or is it maybe different average effective blood levels using the oral? Is there a palpable difference, or do we know why?
Well, I tell you what, my knowledge is limited because I don't prescribe, but all I know is that, that the oral is systemic. And because it's systemic and can, affect, a lot of other areas of the body versus a transdermal, which cannot. It bypasses a lot of different areas of the body. And I'm assuming, organs or whatnot, but if Dr. Rao or Dr. Gorodeski Baskin, I never call you by your first name because I always mess it up. I'm sorry. They may have a better answer for you, but that is my understanding of why transdermal would be considered safer compared to oral. But I appreciate the question.
Thank you.
Mm-hmm.
Revital, my only understanding is that the amount, the serum levels of transdermal estrogens are considerably lower than oral, but I don't know if you have any other.
I don't, because I usually don't administer it, but I think that it probably goes through a different digestion, liver metabolism when it's oral rather than transdermal, and therefore that's kind of how this affects it.
If there's no other comments, we can end a few minutes early. Turn things back to Andy for a moment.
Just as a reminder, our May webinar is open for registration, and you can go through the QR code or through our website. We have all past and present echo recordings on our website as well. Next slide. And then a post-clinic survey was sent to you. Please complete that by 5 p.m. tomorrow. If you haven't submitted cases or have extras to submit, please feel free. And I did send out a schedule again this week. Please let me know as soon as possible if you can't present on your assigned day.
Okay, thank you, Andy. Thanks, everyone. Thanks to Revital and Danette. Great presentations, and we'll see you all next week. Take care.